that work okay? Does everything look all right?
I can see it great.
Perfect. I realized I used the Western Psych slide set, so I probably should not have done that. I apologize.
That's okay.
Just I copied over an old slide set.
We'll wait for everyone to get here and then we'll do introductions.
I'll actually stop sharing until then so that people can see our faces.
Sure, no problem. All right, I think we can go ahead and get started to respect everyone's time. My name is Marin Luno. I'm one of the Peds Emergency Medicine physicians here at Children's, and I'm also the chair of our MOC Part 4 committee. And we are excited to bring you our quality improvement series today. I'd like to introduce our speakers. Our first speaker is Dr. Jim Coons. Jim Coons is a clinical pharmacist who specializes in cardiovascular pharmacotherapy at UPMC Presbyterian Hospital and is a professor at the University of Pittsburgh School of Pharmacy. He also serves as the PGY2 Cardiology Pharmacy Residency Program Director at UPMC and Fellowship Director for the Implementation Science and Pharmacoanalytics. Dr. Coons is a fellow of the American College of Clinical Pharmacy and the American College of Cardiology. He is also a board-certified cardiology pharmacist. His current practice is in the management of patients with advanced heart failure and pulmonary hypertension. His clinical practice and research also include pharmacogenomics implementation in the interventional cardiology setting. So welcome, Dr. Coons. Our second speaker is Dr. Priya Gopalan. She is an associate professor of psychiatry and OB-GYN at the University of Pittsburgh School of Medicine. She currently serves as the medical director of the Consultation Liaison Services Chief of Psychiatry at McGee Women's Hospital, and is one of the faculty advisors to the Psychiatry Residency's Academic Administrator Clinical Educator track. She co-directs the Women's Mental Health Area of Concentration for Psychiatry residents at Western Psychiatric Hospital. Her interests include consultation, liaison psychiatry, women's mental health, resident education, and hospital administration. So welcome, Dr. Coons and Dr. Gopalan. We're really looking forward to your presentation today.
Thank you for that intro. So I'm going to go ahead and share my screen here. Can everyone see that okay? And it's in the right view, it's in the right, like, not presenter view.
Perfect. Thank you.
Perfect. Okay. So we are going to be talking a little bit about just quality improvement from sort of 101 for clinician educators with a focus on dissemination, because that tends to be the part I think that's the hardest for individuals. You know, people have really wonderful ideas and implement these really amazing projects, but then sort of the next steps of what to do with that is really what we're going to be focusing on, both in terms of publication, but also just dissemination more broadly, if I can get my slides to go forward. So we're going to be talking about conceptualizing QI projects into a format that actually is conducive to dissemination, thinking about avenues for dissemination for clinician educator faculty, which is very different than the research faculty kind of world, and brainstorming kind of practical ways to move projects forward. And we'll be doing it with the following format. So I'm going to give you a little bit of time to get to know us just a little bit, with a little bit more detail in terms of what we do and how we got into this area to begin with, and why we are talking to you all. And then we're going to be talking a little bit about nuts and bolts of QI and publication in particular. And then we're going to open it up for discussion. You know, any projects that you're working on that you want to sort of share with the group and get some thoughts and input on, we'll sort of do that. But first, we're going to start with the more didactic part of this. So introductions, I'm going to invite my colleague, Dr. Coons, to start off, and then I can tell you a little bit about myself as well. Dr. Coons.
Yeah, sure thing. Again, thank you for the invite and for the opportunity to present and you know, share some insight in terms of, you know, conducting and publishing QI. So I guess just briefly beyond the nice introduction, you know, I get involved in a lot of you know, kind of medication related, you know, QI initiatives as an extension of my practice. Obviously, I'm a pharmacist, so you know, a lot of the questions that I get about performing QI really come from, you know, my involvement in direct patient care. So looking at, you know, gaps in care, you know, clinical controversies, unanswered questions, real world evidence. So a lot of the things that, you know, I see day to day are what lead to, you know, my QI involvement. So I'll be talking a little bit later on about, again, I think more of the nuts and bolts of publishing QI and how to really see that process through. You know, as was stated earlier, you know, we know that there's a lot of great, you know, QI related ideas out there, and our goal is really to help you to be able to successfully disseminate your findings and see it through to publication. And we'll go through, I think, a nice use case at the very end, and certainly would love to get other examples and questions from you all to kind of help you through that process.
And like Dr. Luno said before, I'm Priya Gopalan. I'm with the Department of Psychiatry and sort of fell into quality improvement by accident a little bit. So pretty early on in my career, I took on a position as the medical director of our team, and the consult service I direct spans 9 of the hospitals within the UPMC system. So it's a very large team, and I learned very quickly that if you didn't have data and outcomes, it was hard to talk to administrators, frankly. So it ended up being an exercise in kind of learning how to take the initiatives that we were doing across this pretty vast team and vast system and packaging it in a way that administrators kind of understood, but also, you know, that leaders across the system kind of understood, because once they sort of got it, then they really understood the value of the clinical care service that was happening. And then around the same time that I took over the consult service, I also took over as one of the 2 faculty advisors for our residents academic administrator clinician educator track. And that track is really designed for our psych residents who are interested in academic careers, but who are not necessarily interested in research careers. So we get a mix, and we have usually about, you know, somewhere between 8 and 11 residents per year who do this track, and their interests vary from people who want to be just hardcore clinician educators, like, wanting to teach and course direct and maybe go down the path of program directorship or clerkship directorship, that kind of thing, but also a fair number of people who want to do administrative work and want to become medical directors, and at least 1 or 2 per year who want to learn more about the business side of medicine and quality improvement. So we've designed a track that actually addresses all of these needs, which is great. But as part of the faculty, as being one of the faculty advisors for the track, I had to be in a place where I could prepare myself to actually advise people who are interested in quality improvement as well. So that's sort of how I got into this area. It was mostly through administrative work, but partly through the work that I do with the residents. So that was sort of we wanted to make sure that you all had an understanding of our paths and why we're actually sitting here talking to you about this topic, to begin with. And I just wanted to also say, I actually can't see the chat right now. So I know, Maren, you said you were going to moderate. And the reason I bring that up is because I'm actually going to open us out with a question for our audience. And you can either put this in the chat if Maren wouldn't mind sort of reading it out to us, or you could unmute and sort of say this out loud. So why disseminate? Why do we care? Any thoughts or ideas on that?
We don't really have any participants in the chat. Oh, here we go. So Dr. Clark said so people can learn from our projects.
Okay.
Dr. Johansson said to build the evidence base for a topic.
Yes, absolutely. So, I mean, we chose jobs where where we're working for a large academic institution, right? So I think dissemination becomes part of adding to the evidence base, allowing people to understand what we're doing and how and why, developing best practices if you're not a researcher in terms of the clinical work that you're doing. It's just part of the academic environment, right? So, I think those are
a couple other come up as well.
Yeah, what else?
Sorry, I don't mean to interrupt. It said aiding in collaboration, sharing our experiences, giving ideas about projects for other people's setting, and avoiding reinventing the wheel.
Absolutely, right. So this is where you get to sort of put forward what you've been doing, let other people learn from your sort of experiences, positive and negative, and really fostering those kind of collaborations that ends up being just a fun part of what we do, right? And then from a more practical kind of standpoint, it's part of the promotions pathway, right, in an academic institution. So I'm going to read out this because I know some of you may be on phones, and may also just not be on a large enough screen to see this. But, if you pull the PIT clinician educator pathway for faculty, there are parts of this that are pretty relevant to the topic that we're talking about today. So, part of the things that are encouraged are things like a record of scholarly contributions to knowledge. And it says typically, this is for associate professors. So typically 10 peer-reviewed original publications or publication equivalent scholarly products. So that's, an area that is very sort of concretely defined with the School of Medicine. Evidence of innovation by creation and dissemination. So again, these are things that you all are working on. Record of high quality patient care, record of high quality teaching, record of robust service, right? So being able to package the incredible work, Did someone say something?
I think maybe that was just someone who wasn't on mute.
Okay, sorry. So these are really good sort of practical reasons just for your own personal promotion and growth. Why being able to package the work you're doing into something that is disseminable and is a concrete product would be really, worthwhile for you. And I think it's important to really think about quality improvement in the context of what's interesting to you. So for some people, this might be a quality improvement project related to some type of teaching initiative that they're doing, whether it's, bedside staff or, trainees or something along those lines. I know it's a little bit looser of a definition of quality improvement, but certainly it's something to think about in terms of dissemination. It might be something more hands-on clinical skills related to simulation, a training, something along those lines. It might be something a little bit broader in terms of, teaching or education or just development of, something team related. It's just, you have to think about what sorts of things really drive your passion, because I can guarantee that if you want to disseminate something, it has to be something that you're really passionate about. So I'm going to open this up for participation again, but what are you working on? What are some projects or ideas that you think are worthy of dissemination? And I'm sort of putting that word in quotes here, because I don't think we probably think broadly enough about what kinds of things could be published. So does anyone have anything that they're working on currently or have finished that they think might be something that you could disseminate in some capacity? It doesn't have to be a manuscript. Any thoughts or ideas?
So I'm the coordinator for the Children's Hospital Interdisciplinary Prader-Willi Syndrome Clinic.
Mm-hmm.
And I did a QI in 2019, 2020 about how having an interdisciplinary clinic helps with quality of life of the family. And I think this can be really important to publish in order to show that we need to have support for this clinic and hopefully get more disciplines involved.
Absolutely. And really to kind of show off what you're doing too, right? I'm willing to bet, and peds is not my world, obviously, but I'm willing to bet that that's a pretty innovative clinic that you have there that's not widely available across the country. So I think it's important to sort of get the word out too. That's perfect.
Yeah.
Anyone else? Anyone else have things that they're working on or have worked on or are part of clinical programs or things that you think would be worthy of getting the word out?
We're working on reevaluating the transaminase levels for when to obtain abdominal imaging when there's concerns for physical abuse. Because we use a different cutoff. We recommend a different cutoff than the trauma guidelines. So we're trying to see if we can save some radiation. And then we're also working on a STI testing in pre-pubertal children during the evaluation for sexual abuse, and what's the yield of that testing.
So you're taking a very practical, sort of widely sort of experienced clinical scenario and saying, you know what, the way we're thinking about this nationally is probably not exactly right. Let's try to flip that a little bit. So really introducing a new idea or protocol. Anybody else or anything, any other areas?
We had I think it's Dr. Hei Chong, say they're working on an algorithm for docs to give penicillin again in their office to clear a patient allergy.
Perfect. So again, a very sort of a different way of flipping clinical care. And the reason I sort of put this out there first, and really kind of at the beginning of our conversation here, is because I think we sometimes don't think about what we're doing as being particularly innovative or unique or different. When in reality, I would guess that, 80% of what you're doing and what you're thinking about is actually pretty unique just by nature of being here in a large academic institution with a very rigorous, infrastructure for clinical work. So I put in a couple of things that I have done over the years, and I've been working at UPMC as an attending for the last decade. But these are not really like, cutting edge, latest scientific discovery sorts of things, right? So this is why I've sort of picked a couple just to highlight, not because I'm trying to show off the work that I'm doing, but just to say, you know what, just to show you that this is not something that you have to overthink in terms of publication. And I think the ideas that you've presented are actually much more cutting edge than some of the things that I have published on. So, the one at the bottom left is actually the one that I'm probably the most, it was like the very first really quality improvement minded thing that I ever published. And that was just really on something very basic that I do clinically all the time, which is manage, benzodiazepine withdrawal in pregnant women at McGee. And it turns out that not very many people have actually published on this, even though one would think that it would be a really commonly sort of written about area. So, pulling together just who I saw and putting that together in terms of observational data ended up being something that got accepted as a manuscript. Similarly, I mentioned that there are 9 hospitals that are under my window or under my medical directorship. So one of those hospitals, we do consults to their labor and delivery unit via telepsychiatry consults. And, as it turns out, there are not that many places across the country that actually do this type of work, and even fewer who publish on that type of work. So it ended up being pretty straightforward to put together a descriptive analysis on just who we saw and what types of diagnoses and what kinds of areas we were managing and that type of thing, just by looking backwards at our notes. And then the ones that I have listed on the right are ones that I did when they were published. The individuals on the first authors on those lists were trainees. They're no longer obviously trainees, but working with residents and fellows has definitely extended my abilities in terms of doing some of this work. And I know Dr. Coons had a few papers that probably follow similar trajectories. So I'm going to turn it over to him for a second to talk about some of his work as well.
Yeah, I would echo a lot of what you said. Again, I think that a lot of this, for me, it is really a product of kind of, making a point to write when you can as an extension of your practice. Obviously, we're all crunched for time, and that's hard to do. But I think making the time to do that is important. And again, I think the other point that was made earlier too is about writing about things that you're passionate about. I mean, just hearing some of the examples already, I mean, there's clearly a lot of very innovative things that are that you're all doing, in your practices. And I think committing to to sort of a writing plan and getting those out there, I think is key. And some of the work that I've done, I think, is really a mix of of clinical things, kind of new practice patterns, some comparative effectiveness and safety, some educational interventions, just kind of a variety of things that sort of reflect my role as kind of a clinician and educator.
So I know you all have had other lectures related to quality improvement, so you are probably extremely familiar with the PDSA cycle, but really wanted to just highlight that if you follow this type of a model, it is actually very conducive to allow you to disseminate. So if you set up the planning part of this in a very structured way and really think about pre and post, or is there a way to incorporate some type of objective needs assessment, a survey, something along those lines as you're doing the planning, then it'll become just a million times easier to publish later. And then, of course, when you're doing the studying portion of it, to make sure that you're thinking about data, or you're thinking about other outcomes and parameters. So just to give you an example, right now we are talking about, I mentioned the telepsychiatry OB consults to their OB unit over at UPMC Northwest. We are talking about adding on UPMC Hammett just for the OB units, like they want to access our consult service. So as part of that, we're starting with like just a needs assessment. Let's see what the the inpatient bedside nurses want to do for that. So sort of that planning stage. Let's see what their knowledge, attitude, and comfort is related to mental health and mental health integration to OB. And then we then have a couple of different directions we can take it, right? So once we do the doing part in terms of the actual clinical initiative, then we have the option then to resurvey, or even just to use that initial survey to guide our planning, and just sort of leaving it with that. But at least having a structure to it then allows us to disseminate if we want to, if we choose to do so. So other kind of core principles of quality improvement, kind of these SMART parameters, right? Being specific, measurable, achievable, and result-oriented and time scheduled, actually is really conducive to dissemination, right? Because this is actually what you want when you think about looking at outcomes. So I just, if you're using any of these models to design your quality improvement projects, then it actually really does allow for a lot of scope for dissemination. I am a big believer that you should use any kind of external deadline to guide you. I think most of us tend to be a little bit deadline driven. That would be my guess. Maybe there are some others who are not in need of that type of thing. But so I tend to use conferences as my deadlines, both for quality improvement projects, but also for dissemination. So there's one that I go to every year in November. It's the CL Psychiatry, it's the Consult Psychiatry Conference. It's a big national conference just for consult psychiatry. The abstract deadline is always in April. So I will try to think about setting up quality improvement so that I at least have some preliminary data of some sort by that April 1st deadline, so that I have something to present. And then the nice thing about that is, and just sort of an aside to that, you can be very broad in the types of things that you present at these types of meetings. So this is just an example of a couple of years ago, and I'll read out what some of these are, but it's, physical exam for a psychiatrist, which is not something that maybe the psychiatry world talks about as much as we probably should be, but that's something that we have presented in these types of meetings. We talk about care delivery models. We talk about just basic sort of things that we're doing in our day-to-day practice, and understanding that not every conference is going to allow this type of work to be disseminated. But some of our posters are case presentations, some of them are quality improvement projects, some of them are just how we teach and learn and how we provide clinical care. So, thinking about conferences as a way to put some of that work forward. And then I usually tell the trainees that I mentor that you should always consider poster to paper or symposium to paper as the next step. So usually after the conference has happened in November and I get the feedback that I need, then I will use the abstract as my base, and then sort of build on if there's a poster or if there are PowerPoint slides, I'll sort of copy and paste in. And then you already have the foundation of a pretty good paper right there. So, I'm a big fan of this sort of poster to paper, like conference submission, poster or symposium, and then paper as the next step of that, because I think it sort of fits a deadline driven model that a lot of us need. And half the work has been done, right? Like you can just, you sort of think of it as there's the abstract's your outline, and you kind of move from there. I work a lot with trainees, so I just wanted to say a word about that piece of it. Trainee engagement can really help to expand your reach and scope, because I know everybody's extremely busy. People are busy clinically, people are busy in terms of education and other responsibilities. So sometimes trainee engagement can be helpful as long as you sort of do it the right way. It is definitely not a time saver necessarily if you're mentoring appropriately, but I do think having extra person power can always be helpful for projects, and it's just more fun to do. But you have to understand trainee skill levels and their approaches. Are they more proactive? Do they need tighter deadlines, that sort of thing? You have to be approachable when it comes to that. I've sort of shifted my thinking around mentorship though. Like I used to sort of read mentorship articles, and it would always say like, the mentee is the one who has to approach and do this type of outreach to you. But I'm not sure that I believe that. So I think, reaching out to them and saying like, look, I have this project. Would you like to help me with it? Can you help me with the write-up? Can you like write the, these sections of the paper or something like that, can be super helpful for kind of expanding your reach as well. But, inherently quality improvement is going to have some barriers that go along with it. I think, the most obvious one is that most QI projects are single site projects, which from a publication standpoint is a huge limitation. And a lot of journals don't really love that from a publishing standpoint. So it is harder to get quality improvement projects published as a whole. And especially because QI study design is not, we're not doing randomized trials. We're not doing control groups typically. So it is often a less rigorous study design. And of course, we're not grant funded. Most of us, I'm guessing, are not grant funded researchers with a lot of extra free time to do this type of work. So just to sort of pull together what I've been talking about so far, as much as you can, put structure to what you do, sort of build it into your workflow already, so you don't have to like set aside separate, time to do some of this. Use your deadlines as you can. One thing I didn't talk about before, but has been very helpful for me as an administrator, is to really get familiar with Excel and data, and take some, look at some YouTube videos, take some classes, do whatever. But really being able to pull some data, to pull and sort and mine data can be really helpful. It doesn't have to be really complicated, but just understanding basics of like how to get means and medians and averages and doing graphs with trend lines and that kind of thing can be very helpful in quality improvement. And then really understanding the journals in your area of subspecialty interest can be useful, and knowing which ones take single site initiatives and quality improvement projects and that kind of thing. And with that, I'm going to actually hand it over to Dr. Coons to take over. And Dr. Coons, if you want to tell me what the advanced slides, I'm happy to do it that way, or if you want to share screen.
Yeah, that'd be great. I guess while we transitioned this part, I wanted to just pause and see if anybody had any questions or comments about anything that was covered so far. And if not, the other question I wanted to pose for the group is, what types of barriers have you encountered in terms of writing up a QI project? Please feel free to either speak up or type in the chat, and we'll give you a moment to provide those.
Sometimes getting the data, submitting a data warehouse report, and then depending on their projects, there can be some time lag to that.
Absolutely. Yeah, that's a big one and certainly needs to be considered, as early as possible, ideally. Sometimes there's unforeseen things when you're expecting to get data on a certain time frame. Other times there might be data that you ended up needing to collect that maybe wasn't anticipated initially, but certainly that's a factor. Has anybody else encountered any other barriers?
Honestly, it can be the last thing I want to try to do after a clinical day. So there's that.
Yeah, no, thanks for providing that. That's a really important one, and I think one that we all face, So I'm not sure I have an easy answer for that one, other than, again, just, making the time, which is hard, right? So it's a time factor, but it's also part of that passion for, for wanting to be able to disseminate, the great work that you're doing. So it does require that level of persistence because we're all faced with the time crunch.
Terrible writer's block. I just sit down and my mind goes blank.
Yeah, I mean that that can certainly happen too, and I think putting together a group of stakeholders who are involved in QI, I guess your co-investigators or collaborators, is important. You may need to lean on those people if you do get stuck, and being able to delegate different sections, I think, can help ensure that the project moves along.
I have a couple of suggestions on that sort of hit on all of these, if it's okay for me to jump in on that, Dr. Coons. So I think that delegating with collaborators is huge. What we have done for some of our project write-ups, I should say, is to just open a shared document on OneDrive and have it outlined. Like you could, as first author, you would have it outlined at least, but then, delegate the subsections. And then usually what we do is just a weekly 10-minute check-in meeting to sort of say with some deadlines. So, every week at 8:30 when I'm driving in to work, or 8 o'clock when I'm driving into work, we're going to do a quick phone touch base to see what needs to be done next, and then set some deadlines for the following week. And then it ends up being a little bit easier because you have some accountability, frankly. But that helps a little bit. And then from a writer's block standpoint, there's a faculty member in the Department of Psychiatry who says, and this doesn't actually work for me, but it has worked for a lot of my colleagues, is to write one bad paragraph every day. So 15 minutes, or 15 minutes of bad writing, or 10 minutes, one bad paragraph is what he says. Because then at least you get something out there. It doesn't have to be your best work, because I think a lot of times writer's block is just our own internal drive for perfection, which, if you sort of reframe the thinking into one bad paragraph a day, then that could be helpful to sort of help with that as well. From a data standpoint, though, that is just a perpetual issue, and such that sometimes I will actually just do the data mining myself, like go through the QI board, get permission to access charts, and just pull it and do it myself when I'm watching TV or something in the evening, something kind of mindless. Or you look at what data you already have access to. So in our consult office, we have 2 AAs who keep data for me because I've asked them to, just like volume data and transfer data, that sort of thing, because I don't want to bother with going through a lot of these requests, and it's a pretty easy pull. And then what you can then do is you take the data that you do have and you see what you can sort of pull from it to disseminate. So I'm going to stop talking there, Dr. Coons.
Yeah, no, that's a great point. There was another comment in the chat too about difficulty with running the data query. for a retrospective review using ICD codes. I don't know if you have a comment on that one. I can comment as well.
You can go ahead.
Oh,
I
yeah,
don't,
no.
I don't-
So I think it's an important consideration, right? Because depending on the project, there might be a need for you or somebody on your team to run the data, or maybe you're relying on somebody else, who has a little more data expertise to do that. And the issue of ICD codes, is certainly prevalent when it comes to retrospective projects, ensuring that you have a complete list and you're doing the correct search. So I'm not sure what the exact nature was with this person's comment, if it was just a matter of finding the right codes or getting access to data. But I can tell you, in my personal experience, I've definitely reached out to people who have far more expertise than me when it comes to doing these types of queries. I know in my practice at the School of Pharmacy, we work with an honest broker quite a bit for oftentimes more research, but sometimes that does involve QI, somebody who can extract data, in a sometimes a de-identified way.
Yeah, I think the biggest issue with ICD codes in general is just that we tend to be very bad about inputting it. But yeah, without knowing the structure of children's quite as much, it's a little bit harder to answer this. But we have a couple of people at Western Psych who are data minded, but they don't really understand necessarily the full scope of the clinical work that we do. So my suggestion for that is to really be very clear on what you need, and then they can sort of give it to you. And then, a lot of the sort of sorting, you can either kind of do yourself using Excel, or you can, tell them how to do it. But for things like that, I would definitely try to get some type of quality analyst or, someone with some statistical expertise involved. And what we have done for some of our resident projects is try to find people in the research track in our program who can help with some of that statistical support, because they are looking for publications, but they have more expertise in that particular aspect of it, and sometimes have more non-clinical time available to kind of do some of that work. So that's one option and one possibility. Once the data query is done, of course, once you actually receive the data. These are great points, though.
Yeah, thanks. So I guess moving on to this final section before we open it up and maybe go through a use case and take additional questions would be, how to write up a QI project for publication. And I wanted to start with a key guideline standard that's out there. I'm not sure how many are familiar with this, but it's called the Squire standards. It's actually Squire 2.0. There've been a couple iterations of this. But if anybody has any familiarity with this or has seen this, please feel free to chime in or add into the chat. It's actually a great resource to really guide you along, and it kind of walks you through the steps of how to compose each section, of your manuscript, and with the specific goal of writing up QI. So it gives you that nice framework for how to report new knowledge on what you did or what you studied, or both, and improve QI in healthcare. This publication, it's been out for a few years now, but a lot of this work in developing, standards and guidelines for reporting quality improvement in healthcare has not been around for all that long. It really just goes back the past, 15 to 20 years. So I think it's a lot less mature than, QI and other fields compared to what we do in healthcare. But because of that, it's intended for these reports that describe any type of system level work that focuses on quality, safety, and value of healthcare. And it helps you to better describe in the methods how the observed outcome was due to the intervention in your QI project, right? Because this is done, oftentimes in kind of a real world setting. There's a lot of other factors that can confound results, and it's really important to describe all the elements of the environment, right? So like you may have done one particular thing, but it needs to be done in a way that other people reading your work outside of the institution could replicate that, right? They need to understand, well, what's different about your local environment if I was going to do something similar and make this work. And I have the citation there provided at the bottom of each of these slides. So it's actually not a long read at all, and it has a really nice table of all the details about what you should include in each of these sections. So the major text sections, again, no surprise here, right? You know, intro, methods, results, discussion. But the fundamental question you want to start with for each of these, so for example, introduction, you know, why did you start, right? I mean, this should be a relatively concise section of the manuscript, usually a couple paragraphs. You know, you want to, you know, basically give, you know, a little bit of background, you know, the nature of the problem, what is known, and then lead right into your rationale and your aims, right? Why did you pursue this? The methods is really going to be the heart, you know, of the manuscript itself. It needs to be very detailed, very explicit. That way it can be translatable. So it's a matter of describing, you know, what did you do, right? So part of that is context, part of that is describing the intervention. So that plan, do, study, act slide that was presented earlier, I think is a really important part of that. And some authors even suggest, you know, taking that PDSA cycle of essentially what you did, right? You could provide that as a figure to minimize the amount of text in the methods, but it really should kind of reflect that cycle of what your intervention actually was. That, of course, the method section is also going to include things like what was measured. So it may be some type of process endpoint that's, you know, it's not as likely to be maybe a clinical outcome, but you want to pick process metrics that are aligned with, you know, clinical outcomes. And then, of course, the analysis. The results, again, going to be very kind of objective in terms of what was observed. And then the discussion is your opportunity to summarize kind of your key findings really in that first paragraph, then provide some interpretation for what it means relative to other reports or studies that were similar in nature. Of course, include a limitations section. And, you know, that would then lead into your final conclusion about usefulness and sustainability of the work. This is from another paper that really talks a lot about these Squire standards, and it's almost written more like an editorial about how the standards came into existence in the current form, and provides, I think, a more distilled down version of what these required elements of the manuscript sections are. So I won't read through that, but I think what was especially useful about this is if you look at that far right-hand column, it illustrates the common pitfalls for each of these sections. So I think that this can help improve the efficiency of getting you started and getting you through, you know, sort of a full write-up. Again, just to point out a couple of quick examples, I think the intro, sometimes this can be far too long or too much importance or focus on importance and not enough on the evidence gap. The aim maybe isn't clearly described. The methods might be a little too superficial. Maybe you don't have the theory behind why you did what you did. We don't always think of it as theory, but theory meaning like the rationale for why you pursued and conducted the study. If there were many intervention steps, maybe those weren't fully described and it was reduced down to a single intervention when it was really much more complex than that. So that needs to be very apparent to the reader as well. Results, they advise against doing kind of a simple before after. I think maybe in the discussion we can get into some examples of how to show results differently. You know, you can, for example, plot, you know, intervention over time and basically show how other factors may have influenced the process outcome of interest. So it's not just kind of a simple, you know, one-to-one, we did this, it resulted in this, but you can sort of show over time maybe what else had changed during your QI project. And then, you know, discussion and conclusions. You know, if it's limited to just implications in your local institution, you kind of want to go beyond that and talk about, you know, how this can improve, you know, QI beyond the local setting. And again, this is your opportunity to really put your results in the context of other findings and give some interpretation for it and talk about, you know, next steps and ultimately why this is important and why it does add to the literature. And lastly, you know, I found this website here. This is actually from Yale School of Medicine, but it actually gives a nice summation of various targets for QI and patient safety, kind of where to send them. So I'd encourage you to take a look at that, but it's organized by, for example, was your project QI and implementation related? There's other journals for kind of more healthcare policy and management. There's some that are specific to medicine, academic medicine, internal medicine, specialty practice, and even other areas such as nursing and pharmacy as well.
Okay. So we were actually going to, and I'm going to stop sharing my screen for just a little bit, if that's okay with everyone, so that we can open this up. Actually, no, I lied. I'm going to put up our prompt questions. Let's get back on here. So let's talk really quickly about some of the projects that you've already mentioned. So we had a few suggestions at the beginning, a Prader-Willi clinic, I think a new protocol for abuse and violence. So I was hoping that maybe those of you who spoke up before, or if there are other projects that people are kind of mulling over, thinking about, if you would be willing to share in our last part, what sort of things would you want to publish, and specifically, maybe some of the individuals who shared some of their projects could tell us whether they have data, and if so, how you might be able to put it together, or if you need suggestions or ideas on how to put it together. Do you have any Excel resources is one of the questions in the chat. And if you go to the Wolf Center, actually they have some resources they actually have some trainings on how to use some of this programming, but also I think some of UPMC has, like, just through their like HR system, I think there's some educational content there as well. But I honestly, sometimes I just go to YouTube because there are so many YouTube videos on how to use like Word and PowerPoint and Excel that can actually be really helpful. Like, how do I do blank in Excel? And you'll be able to find things that can help you. That's actually probably the easiest way to do it. So some of you who've spoken up before, or anyone else who's working on something, any thoughts or ideas that you have that you want to sort of bring to the group to brainstorm?
So I'm the one with the Prader-Willi clinic, and that was actually my dissertation. So putting the publication together wasn't very difficult because it was basically going through my dissertation presentation and putting it in words. One problem I had was stupid COVID. We were not able to really run a lot of the clinic for, so this was a 1-year QI project. So we didn't see our patients from like March 2019 or 2020 through about June. And so I had 7 families, I think, at the beginning with 8 patients. And for follow-up, only 3 did my follow-up questionnaires. So I'm not really sure if I even want to include the follow-up data, or just write about this is what quality of life was at baseline. Because the clinic, I can't really comment on if the clinic made that much of a difference in quality of life because the clinic got screwed up by COVID. But I use the PedsQL questionnaires. Those are standardized questionnaires that you can get permission to use. And then I used Qualtrics, I believe. I had the questionnaires on Qualtrics, and so families did that like on their cell phone. And then I use SPSS for my data. So I just need to finish writing the paper. I need to decide for the results if I'm going to include the follow-up information. So I really just need to apply my backseat to a chair.
Right. Yeah. Which is tough. It's hard when there's so many competing demands, and I think how you approach that particular COVID issue is really dependent on what your target journal is on this too, because there are journals that take more like process papers, in which case you probably don't need to have as much, like more of the descriptive analysis is probably sufficient, but some of that just depends on your target.
Yeah.
Yeah, I would agree. I think you might even consider splitting it up into two papers potentially, right? I mean, you kind of hit the roadblock with COVID and getting the follow-up data.
Mhm.
But if that's something that's still important that you want to do, maybe you do that later, right? And kind of gather that
Sure.
post-pandemic and focus on just kind of the initial write-up just to move it forward.
Yeah, I just need to get this published at this point, and hopefully I'll then be able to take the paper to potential collaborators and say, here, see, we have a problem with quality of life. I have some other publications that other people have written showing that interdisciplinary clinics improve quality of life because, patients come together at one place. Please come play in my medical village. So, well, I say like people need to come out of their medical homes and play in my medical neighborhood.
Yeah, absolutely.
Anyway, that's us.
No, I think your experience really highlights some of the challenges that we run into as clinicians, right? Like, these are just practical clinical scenarios that come up, and then the writing piece, of course, sometimes it's hard just to get it all going and started, but yeah.
Yeah, thanks.
Any other projects that people want to talk about, or things that they're struggling with that they want to move forward but need ideas from the group on how to do it? We did have an initiative that someone had submitted, but I don't think that individual's on the call. So we can use it, or we can run through it, or we could just talk about your, things that you all are working on, which might be more interesting for the group.
Can I bring up, so for penicillin, this is Hei Chong, I'm allergy immunology. So for the penicillin project, part of what we're doing is identifying people when they get admitted with penicillin allergy who may imminently need antibiotics, who are likely to get second line therapies, and we're trying to automate, I guess, a way that we get consulted, go up, take the history, test them or not test them depending on the history, clear them of their allergies so that they can be given the right antibiotic first line treatment as opposed to second or third line treatment based on the antibiotic history. And we did collect preliminary data where we looked at, for instance, we just looked at a small group and found that patients who had C. diff, about 30% of them had penicillin allergy. So it was enriched for penicillin allergy because that's about 10% of people are labeled. So the problem for us is, there's clear benefit, right, to doing this, but how do we measure that benefit for publication? Because this number will be so small. So, I think the bigger studies, you would look at overall impact on cost. Well, what does it cost to now prescribe amoxicillin instead of third generation cephalosporin? And overall it saves the health system X amount of dollars. But how do you measure, we prevented this person from being readmitted with a surgical site infection? Like, how do you measure, what outcomes could we measure that make sense for publication?
Got it. Okay. So I think some of this is a little more straightforward. So, you have found the couple of really interesting takeaways, and I'm saying this as a psychiatrist, so please take this with a grain of salt. You found the interesting takeaways, the interesting associations that are relevant to people who are working in your field, right? So I would probably take the work that you've done as this is your needs assessment, right? Like this is the initiative, the project that you did to show that there is a need to sort of do more work in this area. And in this needs assessment, these, 2 or 3 really interesting things sort of jumped out at you that you think are worth, disseminating and publishing. And then you explain why that is, right? And then for the next step, you sort of repeat what you've done, but with a mind towards some of these other metrics, right? Like we're going to redo what we did with this project, but we're also going to prospectively look at the costs are, we're going to mark who's getting first line versus second line versus third line medications. And then we're going to potentially, harness some of the resources that you have at Children's from a quality standpoint to do some of those measurements, because things like length of stay, you're not going to be able to pull all that, and readmission rates, like those are obtainable. They're not going to be readily obtainable to you. So you would have to have some type of collaborator with your quality division, would be my guess. But I'm saying that, very broadly.
When you say testing, what do you mean by that? Are you referring to sort of evaluating whether it's a true penicillin allergy, or doing?
Exactly.
Okay.
Right,
So,
but 90% of them are not. Okay. So sometimes you can just not even test and give them the drug. So I think, yeah, so it sounds like you were saying we can work to pull some specific factors, like after a certain amount of time that we do this.
Yeah. So I mean, my thought on this is that if 90% of the time this is not a true allergy, like to me that is notable. I don't know if that's a notable, thing in your field, but to me that sounds like the part to sort of emphasize and highlight, and then to design sort of your next steps, like knowing that 90% are not true allergies. How do we design this in a way that shows that probably our interventions are reducing, harm to patient, reducing, exposure to second and third line medications, and sort of using like how many, maybe going backwards at the data set you already have, like how many people are receiving second and third line antibiotics. Let's, design something to sort of reduce that and sort of show that there's an effect there, or there's an impact to the intervention that you're doing. Are there other projects, other initiatives? We have a couple of minutes left. Jim, I don't think I'm going to actually go through the next set of slides, but I did want to at least bring up one of the questions that was raised to us ahead of time, which is what happens if what you did doesn't show an impact? And I think that actually was a really, really good question, because it is hard enough to get these studies published as it is, that, if you end up with something that doesn't show improvement, or just doesn't, isn't shown to be effective for whatever reason, that can be really not only discouraging, but also harder to disseminate with a lot of work put in, obviously, right? So has anyone been in that kind of a situation before? Asking the group before we sort of tackle that question. Has anyone been in that scenario where you did a QI project, or you did some type of project and it just didn't pan out, and you have a lot of data, but you don't know what to sort of do with it?
I guess we've been working in the ED on a project on videotaping our intubations, and we'd kind of had some improvement of raising the number, but it seemed like for a variety of factors, we just really couldn't get that number consistently over 20 to 30% of the intubations being recorded.
Got it. Okay. Yeah, I mean, these are pretty challenging situations, because again, single site studies are already kind of at a disadvantage, and there's publication bias towards positive studies, right? So I would suggest in these scenarios to focus more on process, and if there's a negative outcome, to really focus the discussion in on why that would be, whether it's that COVID impacted your workflow, which was the example that we had gotten, and perhaps a factor in some of the work that you all have been talking about as well. But that's probably where I would focus. Like, why is it 20 to 30%? Why wasn't that a higher number? And really focus. But again, this also means you have to find the appropriate journal that would be okay with more of a process narrative.
Yeah, I agree with that. I would just add that, even though there is that publication bias, with kind of quote negative findings, I think in QI there is an opportunity, right? I think, if your intervention was unsuccessful, I think one thing to look at would be like the fidelity of the intervention. So is it like consistently or reliably used or followed? Maybe you had this kind of great tool, I don't know, some type of order set or pathway or something that should have worked, but maybe it wasn't used for whatever reason, due to some other mitigating circumstance. I think even just describing that would serve as kind of a next step, for others to evaluate it further.
Great. Well, anyone else have any final questions or thoughts? If not, I think we're right at time.
Great. Thank you so much, Dr. Coons and Dr. Gopalan, for working with us. We really appreciate it. As I put in the chat, please remember, if you guys have MOC projects you're working on, don't hesitate to apply for credit through the MOC Part 4 Portfolio Committee. It is not a requirement that you have a publication to apply through us, but it's also a great way to get some of these resources. And I put a link to our website on the in the chat. And thank you again. We really appreciate your time attending, and we really appreciate Dr. Coons and Dr. Gopalan taking the time to present to us today.
Thanks for having us.
Thank you.
Great.